Welcome to the webinar, Digital Dentures and Overdentures, Clinical and Laboratory Workflows that Go Beyond Denture Basics. This lecture is being presented by Tremaine Watkins, CDT, and we're going to begin shortly. And with that, it is my pleasure to introduce Tremaine Watkins, CDT. He is our Director of Strategic Education. Tremaine Watkins, BA, CDT, has been working in the dental industry, the dental laboratory industry for more than 35 years. He has extensive experience fabricating analog and digital prosthetics with experience in implant-supported and retained restoration. A respected lecturer on both laboratory and clinical aspects of restorative dentistry, Tremaine trains technicians and provides clinical support in case planning, troubleshooting, and implant placement. And with that, it is my pleasure to say, take it away, Tremaine.
Hi, everybody. Thank you very much for joining in. I really did my best with this to make it a two-part course. Sometimes I've been to things where it's two parts, and the first part is its own thing, and then the second part is a repeat of part of the first part. So you'll notice that I'll reference our previous presentation quite a bit in this. So if you weren't able to attend, I know Jessica will make it available in as an on-demand, and maybe it is already. And Jessica does such a great job. You guys, all that this happens, I'm the pretty face, I come in and do my part, but everything else that makes this work is her and a couple other folks at education. So it's really amazing. Thank you, Jessica, for all you do for the dental community. All right, so we're going to build on our previous discussion, and we're going to talk about some of the intrinsic advantages of digital dentures, and then we're going to cover the details of both the clinical and the digital laboratory workflows associated with them. When I first heard about digital dentures, it seemed like a gimmick to me, honestly. And I was like, well, we've been doing them this way since the 40s. You know, why do we need to do anything different? Well, I think it's the 60s. Long time, since before I was even doing labs, let's say that. So I think you'll find both from a practical aspect and also from a, what's the word I'm looking for, a theoretic aspect, you can see why a digitally fabricated denture has a better chance of being a really good denture than otherwise. We're also going to talk about digital overdentures and a workflow for them. Stay tuned for National Dentex as a whole to see more on that. One thing I wanted to do when before I got going was correct something that I said before. I especially wanted to say thank you to Dr. Charlin for pushing me on this a little bit. Last time I said you should store analog dentures not in water, just leave them dry, and that was wrong. Dr. Charlin's like, are you sure? I've always told my patients something else. So I dug around a little bit, and I found an American College of Prosthodontists position paper which said that they should be stored in water overnight. I think what I was confused about is that digital dentures are supposed to be stored dry. So again, thank you for pushing me a little bit on that. I really appreciate it. Sorry for the wrong information before. So just to clarify, if you have an analog denture that's been processed in some way, either injection or heat processed or pour technique, that should be stored in water. And if you have a printed denture, it should be stored dry. I have the document, so if anyone wants to reach out through the education department, and I can send that to you. And it points out what Jessica was saying. Thanks for asking questions. If nobody'd asked a question, we wouldn't have gotten that straightened out. Here's my presenter disclosure. I am a full-time employee of National Dentex Corporation. I was paid to create this presentation, but other than that, I have no financial support by any vendors or anything like that. So any products that I mention or whatever are just things that I've seen work well. So let's get going on our presentation. So in our last course, we spent quite a bit of time talking about how we evaluate patients as potential candidates for removable prosthetics, a good way of repeatedly going through a pre-treatment evaluation process, and then the clinical and laboratory steps in doing analog dentures. Yeah, I'm off by 10 years. The analog denture workflow is perfected in the 50s, and it can work seamlessly. Like we talked about, if we invest the time up front, we can get a good result. With a patient with no denture, where we're doing all the steps, including the custom tray, you're looking at 5 appointments. But if you have 5 45-minute appointments at your average of $6 a minute, you have $1,350 in office costs plus your laboratory fees. So sometimes you kind of get to the point where you're like, why would I even do dentures, especially if you start doing uncompensated post-delivery adjustments. Again, if you do the workflow properly, you can get a predictable result. But what I want to talk about today is that digital can make it even more predictable for you, so you don't get in this situation where you and the patient are not as happy with each other. So, as you guys know, dentures aren't teeth. One of the sources of frustration is instability on the dentures. And if you've evaluated the patient and you've seen that they're a class 3 or class 4, and you're like, no human being is going to be able to make you a stable denture without implants, and they say, well, I don't want implants, and they sign it, okay, fine. It's unfortunate they get a poor result, but you talked about it and they chose not to do it. But if you don't have those conversations, or you don't have them recorded, that can be a real source of problems. And again, digital dentures won't fix a flat ridge, but what they will do is they'll get you, with a proper occlusal design, they'll get you the most stability that you can possibly get on a given patient. One of the other things that, as you guys know, is a problem with analog dentures is tooth delamination. We talked about last time that, the pink base starts out as wax with the analog process. And wax is, unfortunately, it's an excellent separator for acrylic. So we boil and wash and clean and all that stuff to make sure we get the wax off, and we even scrub the intaglio of the teeth with monomer. But sometimes there's a little bit of wax that can contaminate the surface, and then there's a very, very small gap between the acrylic and the teeth can actually pop out, which is not good. It's just part of the denture process, unfortunately. Breakage. I mean, again, if we make our dentures thick enough, they should be fairly resistant to breakage, but if they get dropped on the floor, that's not going to help very much. And the other thing is that there's going to be some patients that can overload our dentures. One of the nice things about printed dentures is some of the latest materials are actually a little bit stronger than the processed materials, as we'll talk about. So that gives you a better option, something sturdier for your patients. One other thing to keep in mind is lost dentures. Lost dentures are probably the worst thing in the analog workflow, because you've done all this work and you look back on, okay, I got the patient a denture, they're happy. And you think about all the work you've done. They show up and they're like, I lost my denture, my dog ate it, whatever. And you're thinking, holy smokes, I get to do all that again. How depressing. Well, digital dentures have some solutions for all these problems. The first thing we want to talk about is how dentures are retained. We kind of think of suction, especially on the maxilla, but really what it is a very, very intimate fit. The better adaptation we have between the passive mucosa and the denture, the more retention the denture is going to have. One of the problems with traditional processing is that acrylic resins have a curing shrinkage of 8%. So we do things in the laboratory, such as injection, and then post-dams, and we'll have to talk about this later because this is important with digital dentures. Post-dams are basically designed to make sure that even with polymerization shrinkage, we still get intimate adaptation at the distal aspect of the palate so that our upper dentures are more stable. So much better, though, for us if we have really intimate adaptation everywhere and we don't really need a post-dam. These little images down on the bottom right here are are an in vitro study that was done of the adaptation between a denture base and the model basically that it was made on. The green areas are areas of perfect fit, and you can see that this was pressed according to the standards, but the polymerization shrinkage is what messes us up. Here, this was built in 50 to 100 micron layers, so you get a fit more like a crown or a bridge, and less like a traditional denture. So I guess what I'm saying is on day one, a digital denture is going to have better mucosal adaptation than even a injected or processed denture. Another advantage to the digital process is that tooth delamination is not impossible, but it's very, very difficult. When digital denture teeth are attached to the denture base, they're bonded similar to how you guys do direct composite bonding in the mouth. So essentially, the product becomes one piece. Not only that, but most of the time when we print or mill denture teeth, we're milling them in chunks, either a roundhouse or at least three blocks. So even though it looks like an individual teeth, it's a group of teeth, so each tooth is not very likely to break out. I mentioned this earlier, but the newest generation, and this is a huge thing, and we'll talk about this more in a minute. The first generation of printed denture materials were not known for their strength or stain resistance. It was a bit of a difficult situation. And so sometimes people got a bad feeling about them, but the latest generation have really high strength. So when our injected resins are oftentimes have a flexural strength of 79 newtons, the new Lucitone digital print resin has a flexural strength of 200 newtons. So you're dealing with just a fundamentally stronger material. It's a composite, not really an acrylic. Do we charge the same if a patient lost their digital denture? There's a couple questions here. I thought I'd address these. If you save the records, I believe we have a fee for a copy denture, and we would do that fee. So it's less than making a whole new denture. Thanks for the question, by the by. Oh, and then there's a good question here. It says, I'm sorry, I joined a little late, but when scanning intraorally, how do you deal with the fact that tissue in the vestibular region on the maxilla has to be stretched in order to provide enough distance to scan the buccal area? Will the stretched tissue provide an adequate vestibule? Short answer is no, but we'll talk about that. Our best processes right now for digital are really kind of a hybrid analog digital process, what we call a reference denture. So I'll talk about that in a minute, but thank you for the question on that. The other thing I was going to say about the strength, kind of getting back to this part of it, is that digital dentures have been shown to be a little more resistant to staining, which can always be a problem with dentures. One of the things that is really helpful for digital dentures as well is that usually we'll have a file for the teeth, a file for the base, and then if you're doing it in exocad, you'll have something called a construction file, which kind of tells the software how to fine-tune the parts that fit very precisely. And you can save those. So that's all the data that's required to remake a denture. One of the things I would say is that if you're working with your laboratory on digital dentures, I would say, if I were a dentist, I would ask that the laboratory give me the manufacturing files along with my denture. That way I can save it. A lot of our larger laboratories generate lots and lots and lots of data. And while we do save the data as long as we have to, sometimes it's in what we call cold storage, and it can be hard to get to. I think it's better if you're doing digital dentures to make the digital denture file part of your digital chart, so that way you can easily access it and you have it organized by your patient's name. The last thing I want to talk about is continuity, because when I've talked with dentists who have done a lot of digital dentures or who have switched from a pretty heavy analog denture process to a heavy digital denture process, what they found is that they've kind of gotten away from that feeling of, okay, I'm opening the box, I wonder what I'm going to get. There are some things, there's a lot of pressure and braking and different things like that that you have to do, as we saw last time with the analog process, that can lead to, I guess you might say, distortion, damage to the denture during the fabrication process. A tooth can move during processing. You might get something that cracks. You might get a piece that gets chipped when we're devesting. I mean, obviously in the lab, we're trying to pay attention and do a good job, but there's processing acrylic dentures can be kind of a high force process. Like we talked about, you have the pour technique, which helps with that. But with pouring, sometimes the hydrocolloid can get a little bit away from the acrylic and, well, from where the acrylic should be and cause a little bit of discrepancy in fit or different things like that. The cool thing about the digital process is that every voxel is indicated as nothing or a printed object. So when we work on the digital process, we have the file that we made before, and then we make any changes that you requested, and then we can output those changes. So if the try-in fit, the final's going to fit. If the try-in teeth look good, the final will look good. So you'll find that the unpredictability that sometimes is just a hallmark of analog dentures kind of goes away with the digital process. Any of you that have been to any of my courses on digital have probably seen this slide. And so I'm going to try to focus it on dentures in this point. But as we're getting more and more into the digital world, you'll find that file alignment is very, very important. What I mean by that is that there's some fundamental skills in the analog world. Like if you're going to make a model, you got to know how to mix the model, how long it's got to set, use good quality stone, all that stuff. It creates invisible problems. If you don't do it, that'll make your things not fit and you don't know why. In the digital world, we need to make sure that we get good files, and we need to make sure that the alignment of the files is the same as in the mouth. The most obvious example of this, and the one that I'll use, is taking a bite scan. So let's say you're doing an immediate denture, you scan the upper arch, and so what the software creates is it creates this. It creates a point cloud, and the little points are grouped into triangles. Every point of every triangle is defined as a certain XYZ distance from one imaginary point that's called the origin point. So you scan the upper, you create a file with an origin point. So then you scan the lower. And when you scan the lower, you create a file with another origin point. And that's why in your software, the two don't seem to be related to each other. So then you go to the bite scan stage, and you start scanning like you're supposed to. And all of a sudden, bam, the two of them snap together. And you're like, what's going on? What's happened is that the software has recalculated both files. So now they have the same origin point. So even though one looks like the upper and one looks like the lower, it's essentially one file from an orientation perspective. So why does that matter? As long as we don't deliberately change it, that bite is an intrinsic part of the file. So when I import one, as long as I say, if I import the upper and I say import the lower in the same position, that bite will 100 times out of 100, it'll be correct. What you'll see in our digital denture workflow is sometimes we have to stack a bunch of files. And so what happens when we stack them is that we take two files that have different origin points. We find common locations on the two. We tell the software, okay, these areas are common, and then it'll show us a map of how well things match up. We make a determination as to if it's good or not, and then we say align. When those two files are aligned, now their origin points are the same too. So you're like, why do I care about this? The reason you care about this is you want to make sure when you're doing a series of scans for your laboratory, or for yourself for that matter, that you're creating enough common points between scans that need to be related to each other so that your files can be aligned. Now, one of the interesting things about this is, what does it affect? File alignment rarely affects fit. The prosthetic that's made is going to fit one file. So either the file's accurate or it's not. But where file alignment comes in is when you get unpredictable changes in the bite or in tooth position, not just one tooth, but like all the teeth look like they're rotated or something like that. Oftentimes that can be a file alignment problem. The other thing that you need to think about is there are going to be times where you need to create a file that really isn't necessary to make whatever prosthetic you need, but it's a transitional one that allows two of your important files to be related to each other. To get back to our iOS example, you could think of the bite scan as a transitional scan because you're not really going to use it in the design process, but it's necessary to get the upper and lower arches oriented to each other. So anyhow, enough about that. So patient evaluation. One of the cool things about this is you're going to use your same technique that you learned last time for evaluating your patient. So you'll look at the ACP class and decide, do I want to treat this person or not? Again, to kind of summarize what we talked about last time, class 1 are the most straightforward denture patients, and class 4 are the ones that are extraordinarily difficult. 81% of patients fall into class 1, and class 1 cases in general can be effectively treated at a general practice. So as you're categorizing your patients, most of the time, your class 1 patients are going to be ones that you can feel comfortable treating and that you'll get a good result on. You want to talk about implants. We'll mention this a couple times, but if crowns are not teeth, dentures are way not teeth. And especially when we're dealing with immediate dentures and stuff like that, we need to make sure that our patients understand, like, this is going to feel very different than your teeth do. It doesn't have to. I can use dental implants to create something that'll be much more sturdy for you, but just make sure you've had that conversation, because no matter the best case scenario is that the patient accepts the best treatment and gets the best result. But if the patient chooses not to do what you presented as the best treatment for them, and they get a less than awesome result, then they're like, okay, well, I should listen to doctor because doctor told me the right thing, and it builds your credibility. So I know I beat on this a lot last time, but I just want to mention it again because I find that miscommunication is the path to extremely difficult cases. Oh, this is a good question. How would you add the fabrication data to a patient file? Those files are relatively large unless we only talk about the STL file. Good question. What I would say about that is that I would only save the STL files of the base and the denture teeth. And if it was done in exocad, then I'd save the construction file too. And those 3 files, I email them a lot to around our company, and usually I'm under 35 megs for the whole set. So I mean, it's not nothing, but it's not a huge file. So I think that'll be okay. I guess you got to look at the data, what data capacity you have. But even if you have a cloud service that you use or something like that, a terabyte will store a lot of them. Let's say that. So good question. Thank you very much. Okay. I'm going to try to pay better attention to that tonight. Thank you for the good interaction. It makes it more interesting. Makes it more interesting for me, hopefully for you guys as well. We want to look at the aesthetics of the case. So we want to make sure that we can meet the aesthetic expectations that our patient has. And we also want to make sure that we discuss any aesthetic limitations, because there are definitely limitations. Like we talked about last time, the teeth have to be over the ridge. If the person was born class 3 and they want class 1, kind of tough tamales with a double arch denture. We got to put the teeth where they need to be. And it's better to have that discussion up front and come to a resolution than just have the patient say, oh, well, I thought my teeth would fill in my cheeks. How come they don't? So having that conversation, really important. And again, the VDO, very important. A lot of these patients are missing some vertical dimension of occlusion, and we can easily restore that during our digital process. So one of the things that was a challenge with making this presentation is figuring out there's a bunch of workflows, and I kind of wanted to show all the different workflows that you guys can choose, but at the same time, have it in some kind of decision tree. So I want to give credit to Dr. Wendy Clark at UNC Adams School of Dentistry. I borrowed her decision tree, so thank you to her for letting me do that. So we're going to talk about some pathways that are what we're going to call pure digital, although like we just talked about, there really aren't a lot of pure digital workflows where you go from an iOS scan all the way to the finish because of that distending effect that scanning has on the vestibule. So we'll talk about kind of as digital as you can be, basically. And then we'll also talk about workflows for folks who don't have an iOS scanner, because there are some great workflows where you can use the analog impression techniques we talked about last time and then jump to a digital workflow. So for a dentate patient that needs an immediate denture, we'll talk about that, and that is pure digital. We'll do an iOS scan of the arch before extractions. Then we'll talk about the reference denture workflow, which I think most people would agree is the best workflow for record taking for digital dentures today. The key with this is you have to get the patient to bring in their denture. And we'll talk about some ways you can financially penalize them if they don't, to help them be motivated. The main thing that's really important to communicate with them is that you're using their existing denture and you have to figure out how to verbalize this so they understand it as a custom tray. It really doesn't matter how ugly the teeth are, if it's cracked, if pieces are broken off of it. As long as it's sturdy enough to serve as a custom tray and you can take some pictures of it, we can change everything. So it's really important that the patient knows we're not trying to copy it. We're just trying to get them to a denture more quickly and predictably, so they don't have to come to the office quite as much. And then if a person's edentulous, we're going to talk about using a bite block and then transitioning the bite block into that reference denture workflow. So the immediate denture workflow, 2 appointments. Reference denture is going to be 3 appointments. And the edentulous one will be 4 appointments. And that's one of the things you can tell the patient, I need to charge you X amount additional if you don't bring your denture, because it's going to take 4 appointments. So trying to get everybody aligned on the same page. Again, I kind of mentioned this before, but you can use a custom tray workflow, a custom tray impression today, and get a digital denture just the same as your colleagues that have an intraoral scanner. So don't feel like that's a barrier. So when I put it all together, I'm going to have 5 different workflows. So what I'm going to go through the immediate denture workflow in detail. I'm going to go through the reference denture workflow in detail. And then otherwise, I'll talk about kind of what you change from those for the other 3. So we have a question here. I'm particularly interested in cases dentures on implants. So it's something you're going to talk about more in depth. Thank you. So I am going to talk about a workflow for doing a digital overdenture at the end. I feel like those are the most complex, so I'm focusing on that at the end. But in terms of like all on X, I am doing a course coming up on that, but I feel like that's a whole separate topic. So if we're talking about all on X, no, but if we're talking about locator dentures, yes. Thank you. All right, so I had talked about this before. but I want to say it again. We don't have a fully digital denture workflow at this time, and we may not ever have one. Even if your iOS scanner is awesome at capturing tissue, as one of our participants mentioned, when you put that big old wand in there, it tends to raise the floor of the vestibule, which essentially messes up our impression. So now we can't create a mucostatic registration. So most of the time, we're going to be actually using an impression technique to capture the, using our border molding, all the things we learned last time, but then we're going to digitize that and use a digital workflow from there. Second thing is that both scanning plastic objects like a denture and scanning tissue are difficult. It takes more, it's not only difficult from the camera side, but it's also difficult from the stitching side when the software is building our 3D object. So, so you'll need to kind of practice with your scanner and see how well it works. If you're thinking about a scanner, you might want to look for ones that have a dedicated reference denture or denture workflow built into them, because with some of the newer systems, they actually have tuned up their AI so that it's looking for tissue and it'll get you a better result on tissue. For some of the other systems, you have to figure out a way to turn off the AI trimming so you can get those edentulous scans. So here I go beating on the patient communication again. You guys know this, but you got to make sure you talk to your immediate denture patients. Most of the time, of course, their teeth aren't in really good shape, or else we wouldn't be extracting them all. But they're kind of going to be going from the most stable scenario to the least stable scenario. So they're going to go from having teeth to having a denture with a fit that is intrinsically unstable, because we can't predict exactly where they're going to wind up. So, of course, like we talked about, you could place a series of implants and do a screw retained day of surgery prosthetic. So if your patient says, well, I don't want an unstable restoration, you say, great, let's talk about what we can do for you with dental implants. And if they say, well, I don't want to pay for that, then you say, okay, well, let's talk about our plan to get you the best result that we can. But I think it's really important, especially for your immediate denture patients, that you need to talk to them about, to the best of your ability, what it's going to be like to have an immediate denture and how different that is than the teeth that they had before. So the second thing is you kind of need to decide how you want to do your immediate dentures. You can either do an economy denture that you deliver on the day of surgery and then use a reference denture workflow to make the final, or you can deliver the final denture and plan on doing a reline later. I would recommend the 2-denture approach, because most of the time in the laboratory, when we do an extraction, we do what I call a lab extraction, which is basically trim the, let's say, the model, the surface scan at the necks of the teeth. So you guys all know that when you extract the teeth, the resorption is going to be much greater than that. And so what happens is that a lot of immediate dentures have short, ugly looking teeth. And so if we make a second denture from that, then we can take advantage of the resorption. I mean, it's unfortunate, but since it's there, and put prettier teeth and put them in a more ideal position. So I would recommend the 2-denture approach when you're thinking about that. So one of the cool things about doing an immediate denture scan is that you have teeth. So most scanners scan teeth pretty well. And what you can do with your scanning strategy is try and have a tooth in view most of the time. So if you start out scanning the occlusal, buccal, lingual of the teeth, then you'll start picking up some tissue, and then you can build from there for your scan of the palate and all that stuff. You do need to scan the hamular notch, the retromolar pad, the full palate to the vibrating line, and scan the vestibule as best you can. Again, It's going to be a bit of an issue because of the way that you have to stretch the cheeks for scanning, but hopefully, again, an immediate denture isn't going to fit perfect, but the better you pick up those borders, the better index you're going to have. As you know, with these, you're usually not indexing to the ridge unless you've done staged extractions where like you extract all the posterior teeth, let them heal, and then extract the anterior teeth on the day of surgery to get a more predictable fit. But really, you don't want to scan these like, oh yeah, I'm just scanning for a crown and bridge. You want to scan like you're scanning for a denture that happens to have teeth on it. So really focus on scanning those borders. Have a lot of 2x2s handy. The drier you can keep the tissue, the easier it's going to be to scan. Again, we're doing a full arch restoration, a denture. So make sure that you scan the correct video. Take advantage of the ability of your scanner to scan an open bite. I had a question here. How long should you wait to scan patients with immediate denture since the tissue may be swollen post-surgery? Agreed. I would say you're probably going to want to wait at least, I've heard 6 weeks to 4 months, depending on the person and depending on how stable you want the case to be. The longer you can wait, if the patient can, if your immediate denture is thick enough to where it doesn't break right away and you can keep the patient comfortable with linol, soft liners, that sort of thing, the longer you go, the less time it will be before. In other words, the sooner you make your new denture, the sooner you're going to have to start relining it. So it would be better to wait a little bit longer, let the bone remodeling finish as much as possible. And then that way it'll be, you can tell the patient, if you can wait a little bit longer for me, then you won't have to do your reline so often. We'll talk about that a little later on, but that's part of communicating with your patient about dentures, is that it's not a one and done thing. They'll need to, you'll need to do maintenance because their mouth will continue to change. If you're taking an open bite for your immediate, sometimes what can be nice is use your leaf gauge, get the bite where you need it, squirt some blue mousse in there, and then trim the bite so that you can see the teeth, put it back in, and use that to stabilize the person's bite so you can take a nice open bite scan if you need to. So what do we do in the laboratory? I'm going to show both exocad and 3Shape, which are the two main design softwares that are used. Software systems. It won't be too long before you'll be able to tell. 3Shape tends to have a gray background and exocad tends to have a purple background. So when you get digital previews and stuff like that from your laboratory, once you get used to it, you can kind of tell, I wonder, is my lab using 3Shape or exocad? You can just ask them, of course, but it's a little bit of fun detective work. So in exocad, there's a digital extraction process where you can, the software will try to pick out the tooth. You can kind of paint any areas that it didn't pick, and then it'll cut the tooth off the model. It's a little bit time consuming, but it has the effect of making a watertight model, we call it, so there's no holes in it. Because if you get holes in this part of the model, it makes it difficult to complete your design. Once you're done with that, a lot of times you'll come back with your smoothing tool and just blend that ridge so that the intaglio surface of the immediate denture is will be smoother and easier for the patient to clean. If you want to do, this is what lab extractions look like. Pretty much, again, just cut right to the necks of the teeth here. If you're planning on doing a little bit of alveoplasty, maybe let your lab know, hey, reduce another millimeter, reduce however much you think is going to be ideal. For me, I would sooner have a gap inside my immediate denture because it's easier to fill it up than it is to grind it and make it fit. But you guys can definitely work with your laboratory to set some preferences to make this more predictable. So once you got the teeth extracted, then we can do our tooth design. With digital dentures, there are basically 3 workflows. You can do what's called carded teeth. There are special digital denture teeth that you can buy on cards that have kind of a bullet shaped, almost like an ovate ponic on the intaglio, and the software will punch an ideal hole for them. I don't really like those because I like being able to, if I use non-carded teeth, I can design them however I want, just like a crown and bridge case. So I can make them what I perceive to be perfect, which is nice. Or you can do milled or printed teeth and a milled or printed base. And then the last workflow is there are both printing and milling procedures that allow you to print monolithically. With printing, there's the multi-jet printer that allows you to print both pink and white. And then there's the, I think Ivoclar is the one that I know of the most that has multi-shade pucks for milling. Will these workflows be on the IndieX website? What we do have on our website is our labs that specialize in digital dentures. And so what I would recommend is reach out to either your IndieX territory sales manager or one of the laboratories that handles that and kind of talk about the workflow that you want to do. Because I think what you'll find is that some of these are going to resonate more with where you're at with your practice and kind of talk about, this is what I'd like to do. Does this work well, or would you recommend doing something else? So sort of, I guess that's my answer. Yeah. Anyhow, when you're designing your teeth, what I like is that, thank you for the question. What I like is that you can make your teeth exactly the way you want them, so you get good proportions and all that stuff. And you can do really nice occlusal adjustments as well to set, nice function, all that stuff. One of the things about, I don't remember if I showed you guys virtual articulator or not. exocad and 3Shape have a virtual articulator that'll allow you to program the articulator with the patient's current occlusion and then reproduce that in a function called dynamic occlusion. So that's kind of a cool thing. All right, so you got your teeth design. The next thing is you'll design your denture base. Of course, your laboratory needs to set the borders at the right length, and then the software will kind of propose a pink design, and it's usually pretty marginal. And so you got to kind of shape it up so that it has good anatomy and all that stuff. You'll notice that this doesn't really have nice anatomy, and that's not uncommon on immediate dentures, just because the ridge is much bigger than we think it's going to be. This is kind of what I was talking about why it's nice to make a second denture for your immediate cases, because this will all, once the healing's complete, this will have remodeled quite a bit, and you'll have more room to do nice festooning and all that stuff, so the case looks really pretty. One of the nice things about designing your dentures is that there's a color map that we can turn on that'll show us how thick the denture is in given areas. So that way, I don't know about anybody else, but when I'm tweaking it, I'm getting it all smooth and pretty just the way I like it. It's like one of the areas is red. I'm like, okay, I can't leave it that thin. It's going to break. So then I have to kind of tweak my design a little bit and get it to where I have the right amount of material. So that's really handy. So then once the teeth and base are designed, you got to figure out how to manufacture them. The process of loading them in the printer or mill, we call nesting. So you might hear labs talk about nesting. And with printing especially, the nesting has a huge effect on the physical properties of the material. You'll notice how these teeth are nested at an angle here. That's deliberate, because the angle that the layers of printing are created at has an effect on how sturdy they are. These are images taken inside a carbon printer. Different printers are different, obviously. So once they're printed, these little support fences have to be removed, and then the excess resin is washed off in a IPA bath usually, and then the both parts of the denture are going to be post-cured. But I want to talk about that a little more in the next slide, because that's important. So once the two pieces, like let's say most of the laboratories these days that I'm familiar with are doing print the teeth and print the base. We're getting really strong results, and it gives us maximum flexibility with tooth design. And if we're missing vertical and we got to make short teeth, we don't have to grind the teeth down, because you can't really grind carded printed teeth, but you can make the teeth the exact height that they should be. So once we've basically broken off the little fences and stuff, we'll actually put the teeth and the base together with bonding resins before it goes into post-curing. So one of the cool things about this is that during the heavy-duty cure, when this is finished, the two materials are being bonded together. So if you break one of these or cut through it with a disc, you're not going to see any seam. It's like it essentially becomes one material. The question is, are printed dentures due to shrinkage post-process more accurate than milled dentures? No, I think if you are getting down to microns, a milled denture, as long as the mill can access it, is going to be a little more accurate than a printed denture, because milling tends to be a little more accurate at a micron level. But the main advantage to printing is that milling is really hard. Milling PMMA is really hard on the equipment. It burns up your spindles, which are expensive, and it takes a long time. Milling one denture takes between 2 and 4 hours, so it ties up a big chunk of milling time, and there's no economy of scale. Each denture takes that long. On the other hand, when you're printing, you can printing these, what do we got, 9? If I printed 1 or 9, it takes the same amount of time, because the time for printing is layers. And the other thing is that instead of taking a big chunk of acrylic and grinding it down to make my denture, I'm applying only the resin that I need, so it's less wasteful. And the equipment for printing is more keeping it clean. It doesn't get beat up in the same way that a mill does. So there's my answer for that. There's no wax, so there's nothing to separate these two, so you're not going to get delamination like you could with a processed denture. And the teeth aren't going to move during processing, because there really isn't processing. There's little pockets in the pink. You put your bonding resin in properly with the bonding agent and all that stuff. You guys know about that. And then you push it in there, make sure it's fully seated, and then cure it. So it's not moving, or there's no pressure or whatever. So you get the teeth just where they're supposed to be. Once you've gotten a printed denture bonded together, the post-processing is, the contouring and the stippling and the polishing, all that is very similar to what you do with an analog denture. The main difference is you don't have stone stuck to it. You don't have a parting line from the two parts of the flask. You don't have flash. So you can finish it a little faster. And again, it's more predictable. You're mostly tweaking it for aesthetics rather than really creating the contour in the finishing process. So after it's all polished up, it's ready for delivery. The question is, would you recommend printed immediate denture and then a milled second denture, since it's more accurate 6 weeks to 4 months later? What I would say is that the difference between the two is not relevant for dentures because of the amount of deflection of a tissue. You're talking about the difference between a mill's probably accurate, a good mill's maybe accurate to 10 microns. Printer is 50 to 100 microns. So either is not going to really affect the denture. I would look at what your lab has the most success with. Like I said, in general, milled dentures are very hard to scale. So most laboratories are going to do printed, and you can get a really good fitting. Again, a printed denture or a milled denture is going to fit way better than an analog denture. So I would say I'd print both. I think that you'll get a good result that way. So that would be my recommendation. All right. So, of course, immediate denture, you got to extract all the teeth and do any alveolar contouring. And again, this is where picking up your palate, your vestibules, and that sort of thing are going to be important, because you got to figure out, is my denture seated or not? And since the alveolar ridge isn't really a valid index for it, we just faked it in basically in the laboratory. You'll want to see, am I seated against the palate in the maxilla, or am I seated on the vestibular borders in the mandible on the retromolar pad? You may need to do a little bit of PIP. Everything that I saw said you should have the patient wear the immediate denture continuously for the first 48 hours to act as a plastic bandage. Then you'll probably want to recall them and see how they're doing at that point. Then 7 to 10 days. And then at about 6 to 8 weeks, you'll probably want to look at doing a chairside soft liner to get a little more stability. And this is another time where your nice borders will help you, because then you can, then you'll have a good index for your reline. So that's kind of the digital immediate denture workflow. So let's talk about reference denture workflow. So this is the best way to do a digital denture today. You get your patient to bring their denture, and you start out by making sure there's no huge areas that are missing on the borders. You can see the little bit of compound was added here. And then what we'll do is the same procedure. Can you deepen the embrasures? Chair side. Yes. As long as you have enough thickness. Sometimes with an immediate, the pink resin around the teeth is pretty thin, because the ridge is kind of, again, with lab extractions, we tend to leave the ridge a little bit bigger, like it was with the teeth in place. So, but yes, even though printed dentures are a composite material, technically speaking, you can use a carbide on them like you would. You'll find they grind different than acrylic, but they're not that different. Like the powder they produce is different, but the feel is not that different. You can polish them up with pumice just like you would for a acrylic denture, standard denture. So anyhow, so you want to make sure you have your borders like we talked about. You'll do your border molding with your heavy body material, and then one more time with your light body material. You need to evaluate your impression the same way. So make sure that your reline denture has suction, because the digital denture can fit as well as this, but it can't fit any better. So if you're not getting suction, I would recommend retaking that impression. So once you've gotten the reline done, you're ready to do your aesthetic evaluation. I recommend taking that reline impression first, so that way the denture will be nice and stable for you. And then you want to do, like we see in the picture here, check the midline, check the bite, figure out where CR is in the video. Take your relaxed lips so we can get the incisal edge position. Take your high smile. Take your profile picture so we can see the opening and also the lip support. Make sure that looks good. Again, the photos are the closest your laboratory will usually get to your patients, unless you have a laboratory that's nearby. So the more photos you can give us with the reline denture in place, the more accurately we can make the changes that we need for the try-in. So then once you've gotten your pictures, I would recommend taking a bite registration if you're doing an open bite, because you want to make sure that the patient gets back to the position and holds in the position that you want. Sometimes, when you're scanning, kind of pushes on their cheek and they might inadvertently move their jaw in the wrong direction, and then we start out with the wrong bite. So if you take a bite like this, you can just trim it with your scalpel so you can see the teeth and then scan the bite. So once you've done that, you have all the records you need. Now we need to digitize them with your iOS. So your first step is going to be taking a 360 scan of the denture, and then you'll capture the opposing arch, or the other denture in this case, and then you'll want to replace the reline denture, put your bite material in, and scan the bite. Once you're done with that, you can remove the impression material and adhesive and IPA tends to work well to clean up the patient's denture, give it back to them unaltered, and then send the records to your laboratory and ready to get going. I got a little tip for you on taking that 360 scan. That can be a little bit difficult, and took me a long time to learn this one. For some reason, I always started, I guess I'm a technician, I always started on the teeth. I'd start on the occlusal aspect of the teeth, and I would have a heck of a time getting over this border to capture the intaglio surface. What I learned from Kelly is that I was doing it exactly backwards. What you want to do is start on the intaglio surface, like on a maxillary, start in the middle here and then scan out, out, out in bigger circles. And then as you get out towards the edge, deliberately roll over the edge to try to capture some of that cameo surface. So then once you've done that, you can flip over and find a big area cameo you already have and build the external surface of your scan that way. For the mandible, you want to scan the intaglio start in the retromolar pad area, work your way around like this. And then as you're going through the middle here, roll back and forth again, trying to capture your some of your cameo surface. Don't try to roll over in the retromolar pad area. It's just too hard. Try to find an area here where you pick something up, scan the outer surface. The internal surface and the borders, the scan needs to be perfect because your new digital denture will fit that. So however good the scan is, that's how good the denture will fit. However, on the external surface, it's not absolutely critical to fill in every single hole because it's mostly giving us tooth position and the bite. So perfect scan on the intaglio, as good as you can on the outside. One of the other things you want to keep in mind with this is true of any iOS scan. If you're getting holes in the scan, you don't want to just stay in one spot, scan and scan and scan. Better to come back and patch that part up later because the best scan has all the data we need with the least amount of data points. A smaller scan is better than a bigger scan, data-wise. So better to, again, patch up little areas than scan over and over and over again. Can you go over what steps to do again after scanning the reline impression? Absolutely. So what you want to do is we'll take this 360 scan that we've been talking about and then put this, scan the opposing arch. It's probably easier to do with the denture out. Then put the denture back in, put the bite that you've trimmed in, have the person close into that and take a bite scan on both sides. So you're using this 360 scan as your master arch scan. You're using obviously the opposing scan as the opposing scan and then the bite scan. And here's my mandibular sample. And then here's your bite scan. You can see this is an example of someone who had bite material in there, took a nice scan for us. So you turn in your scans to your laboratory. What are they going to do with it for the reference denture workflow? So this is 3-shape. So if the pictures that you get, the screenshots that you get from your lab look like this, most likely this background, it's being designed in 3-shape. So your laboratory, this particular case was being designed on a model, but normally your laboratory will take the inside of the reference denture and basically turn it inside out to make the model for the fit. And then see how you have this purple outline? This purple outline is the reference denture, or if we're doing a bite block, it's the bite block. And so you can see that as we're setting the new teeth, we can see exactly how those teeth relate to the existing denture or bite block, which can be, of course, very helpful. We'll want to position the teeth. One of the other things that's helpful about double arch denture teeth is that the teeth are imported in denture type occlusion for us. So that way we're less likely to get interferences and stuff like that in the way the teeth are set, like we talked about last time. So this is showing how the teeth are being positioned relative to the ridge here, which is nice. So then just like in exocad, we'll draw our borders, and then you can see that this is not an immediate denture. So we have some depth. So the technician was able to put a little bit of gingival anatomy, and you can see this is pretty exaggerated. So you'll want to talk to your laboratory about what you like, so that we don't get too arts and craftsy if you feel like that's going to be a bit much for your patients. It's really awesome. Again, even with the pink, you can turn that purple shadow on whenever you want to see how do the borders compare with what with the previous denture. There's a question: are most printed teeth 0-degree teeth? I would say most printed teeth are 10 to 15 degree, the ones that I've seen. They're usually not 0, but they don't have a lot of anatomy in them for sure. It says, when choosing teeth, does 3Shape or exocad provide a tooth shape size proposal? Yes, they do. What the 3Shape ones are not bad. The exocad ones, honestly, the proposals that I usually get are just an irritant that kind of gets in my way, because I find that you have to define the first premolar and you got to hit just perfect on it, or else it messes up the proportions between the anterior and posterior teeth. Like I said, what it does do is for double arch cases, it imports the posterior teeth in alignment to each other. So that way you have an ideal occlusion to prevent interferences. So keep in mind that with all these cases, your laboratory can send you a 3D preview. They can send you screenshots, but there's also ways to export the actual STL files. And if you have something like Mesh Mixer, to import it, or even exocad Web Viewer is another nice one, which is a free online viewer. You can actually look at the files in 3D, rotate them, and turn different ones on and off, and all that stuff is pretty cool. So once your laboratory has the design, they'll go ahead and merge, usually into what's called a monoblock. So merge the teeth and the pink into one object and print it all in tooth color. So this takes the place of the setup in the digital process. And this is where it really makes a big difference for you. The printing and post-processing is the same, other than you don't usually bond it, and we usually don't festoon these quite as much, but the fit is the same. And I guess I'll get to that in the next slide. When you're doing your try-in, this try-in will fit exactly the same as your final denture. If it has great fit and everything, great. If it doesn't, it's not going to get any better. So you need to figure something out. Maybe you need to take a reline impression inside or something like that. These prototypes are also strong enough for the patient to wear, so you could send them home for a few days to kind of do it as a test drive and see how it works. As you can see here, you can mark on it, you can grind on it, you can add to it, whatever you want to do. Let your laboratory know what changes you've made, just so that they can be sure that they scan it in as a reference. Here we have a good question. Does 3Shape exocad allow for changing the denture base thickness to accommodate a locator housing pickup, or will the T-shape proposal dictate the denture base thickness? So if you're doing the digital locator workflow with the scan body, the locator becomes, the scan body housing becomes the model. So the software will offset from the model. You can determine how thick you want your resin over the housing. I mean, it'd be all the way across. In other words, how much cutback there is between the bottom of the teeth and the model. It's usually 0.5 millimeter. But you can set that however you want. So we'll usually do 0.8 to a millimeter on a locator case. And again, keeping in mind that the denture teeth are bonded to the pink. So it's not like the pink and the teeth are two things. They're one thing when you're all done. Another question is here, how do you relay changes to the lab with the prototype? So I'd say a couple different ways. First is you can mark on it like this. Second is I would strongly recommend taking another set of photos so your laboratory can see how the try-in sits in the mouth. You can send it in if you want to. And if you don't want to, you can just do a 360 scan of it. Scan the thing, scan the opposing, scan the bite, just like you did. And then your laboratory can, especially if you had to do bite adjustments or something like that, your laboratory can digitally re-articulate the case. This is a good time to talk about post-dam. Remember, the point of a post-dam is to make up for polymerization shrinkage on a traditional process. So you have to decide if you want a post-dam or not. I haven't really heard a consensus. Some people do post-dams that are very similar to kind of the butterfly shape like they do for a analog denture. Some people don't do them at all. So you'll kind of need to decide. My thought would be very minimal because the point of this whole process is to get really good adaptation. So I would probably put a little bit just to be on the safe side because you can always trim it if you need to, but I wouldn't do the huge, you know, almost a millimeter butterfly that you usually do, maybe half a millimeter, something like that. So when this is a lab scanner. So when your lab gets if you choose to send in the prototype, your laboratory can scan it and then put it into the digital plan that we have. One of the things to keep in mind that's kind of cool with, you guys do this with your iOSs, but lab scanners have a thing called a texture scan, which is cool that lets us pick up any markings that you've put on there. Do we need a code for the CE certificate? So Jessica will talk about this more at the end, but to get your CE certificate, you have to stay on till the end, and then you'll get a quiz. When you fill out the quiz, then either it'll be available for download on the NDX education portal, or you'll get it emailed to you, your certificate. So your laboratory can scan anything that you send in if you want. And then go ahead and redesign. There's a couple different ways to do that. Sometimes your laboratory will import the existing try-in as a study model and then redesign to the study model. And at other times, they'll go ahead and alter the previous design. It really depends on if it's a big change or a little change. It kind of depends on the lab. Sometimes it's easier to be able to just start fresh. And sometimes you're like, I just want to tweak it a little bit. Both are equally predictable, so it's kind of a stylistic thing. You'll notice that I'm using the same pictures quite a bit because what I want to do with these is I want to use the same pictures for things that are the same. So once the changes are made after the try-in, your laboratory will print the two pieces, bond them together, finish them up, and send them to you just like with the immediate denture. Oh, look at that. Jessica hooked you up. So listen to Jessica, not to me. She knows how it's done. Thank you, Jessica. And so then your third clinical appointment will be the delivery. Like we talked about last time, you'll want to go through those same 8 steps in your delivery appointment. You'll find that in general, it's going to go pretty quick with a digital denture because again, it's only changed how you wanted it changed. So in other words, if you didn't want the bite changed, the bite's the same. If you didn't want the fit changed, the fit's the same. So that's, I think, one of the things you'll find that you get quickly spoiled about with digital dentures is, well, if I didn't ask for it to get changed, it'll be the same as it was last time. I went to a lecture with, I live in New Mexico, for those of you who don't know, and Dr. Wagner, who's a prosthodontist here, is well known in digital denture circles. He says that 99% of his digital dentures come back with no adjustments. So that's one of the other benefits of this is you can kind of get out of the post-delivery adjustment business, which might be a nice thing for you. However, if you do need to make use your same denture polishing kit that you use. for an acrylic denture, that'd be fine. So you want to instruct your patients on how to care for these dentures. So again, these are stored dry, not like an acrylic. You don't want to store them in water, and they'll want to use a denture brush and a non-abrasive denture paste. It's best if they don't use regular toothpaste because you guys know it's got abrasive in there and it'll wear the surface and get rid of the luster and stuff. They can use commercial cleansers, but they need to be careful, you know, just like any denture. And then you need to get them on a recall schedule. Most offices will do a 24 to 72 hour post-delivery follow-up appointment. After a while, you may decide you want to just do this by telephone with digital dentures if you're not needing to do a lot of adjustments. Normally, you want to do a 3-month and a 6-month after that, just to kind of see how are they doing with their home care and how their soft tissues are looking. Remember to talk to them about adaptation. It'll take them a while to get used to a new denture, even if they've worn a denture for a long time. And remind them that they need to replace their dentures every 5 years and they need to come in for a cleaning. So congrats, you would have just finished your first digital reference denture. It says, why is it not necessary to keep the dentures wet? It has to do with what they're made out of. They're not made out of acrylic. They're actually a printed composite material, and it just doesn't benefit them. They don't have that shrinkage problem that can occur with a analog denture. And I did look that up this time. The denture shouldn't be stored in a moist environment because it'll tend to, it doesn't need it. So it'll help prevent bacteria growth and stuff like that. Can they be relined in office? Yes. So work with your laboratory about what reline materials work the best. Most of them will work with a traditional monomer base, but almost every printed manufacturer has kind of a list of reline resins that work well with them. So so it's best to follow up with your laboratory specifically on that. Jessica, will you do that one? All right. So how do you deal with a person who doesn't have any denture? Can you do a digital workflow for them? Absolutely. Like I said, it's going to take 4 appointments because we're going to have to do a bite block, but that's okay. So, and you can do this analog. One of the things is, since the lecture's on digital, I'm always trying to pick the most digital workflow I can find. So if you want to just take a preliminary impression with a Algin or PVS or whatever, that's fine, because we're going to be doing a border molded impression at our second appointment anyhow. But if you want to do a an iOS scan, you can, again, with the caveat that your vestibular borders will probably be a little bit inaccurate. But this is a scan path from Dr. LaRussa in Italy, and it's become pretty popular for edentulous iOS scans. I would recommend these scanning paths. As you know, with iOS, scan path is huge. If you do a good scan path and you scan at the right speed so that you're capturing data as quickly as is reasonable, not going over areas the same, you'll get a nice result. So after you take these scans, you're not going to scan the bite. You just go ahead and send these to your laboratory and ask for a bite block custom tray combination. Thank you, Jessica. So what your laboratory will do is they'll make a bite block, but it'll be like this, where it'll have additional offset on the intaglio side, and then it'll also be short on the borders. So what you're going to do on this is you're basically going to do a reference denture workflow. So you'll go ahead and check it in the mouth, make sure it seats well, paint it with adhesive, and then do your border molding, just like we talked about before. Once that's seated and you get your nice border molded impression, then you'll go ahead and do the bite block procedure, trim the wax, to get to the correct vertical dimension of occlusion, and then shape it up so that it has the proper lip support, incisal edge position, buccal corridor, all those things. Mark the midline, mark the high smile line, take some pictures of the patient wearing it. Usually you'll have to trim this area so that you can trim all the way down to about here, because all we need to do is get the borders. And then you'll want the patient to bite into CR. Again, a lot of times it's not a bad idea to notch it and take a bite over it, even if you're doing a digital workflow, because it'll help the patient get back into the same position. And then at that point, this is totally like a reference denture. 360 scan of this, scan of the opposing, scan of the bite. Now, again, I'm trying to be digital because it's advertised as digital, but the patient doesn't need this thing or want it. So you're also welcome to scan the opposing and then send in the physical bite and the bite block custom tray, and then we can pour a model in the laboratory and articulate it and scan all that as well. So you don't have to scan this, but if you like digital and you want to scan it, feel free. If not, fine. So now we're back in ExoCAD. See the purple background? So if you send this to the lab, of course, they'll pour a model and then articulate it. One of the things that you can be comfortable with is, of course, you guys know scanning in the mouth is not the most optimum environment. Yeah, I mean, the patient's moving around, you got saliva, it's dark. Our laboratory scanners get to work in an ideal environment, so we can usually the scan, a lab scanner is said to scan at about 10 microns of accuracy, whereas an iOS scanner is usually around 30. So you'll pick up really nice accuracy, so you don't have to worry about that side of it. Yeah, the question is, when you keep saying scan the opposing, you're assuming that the opposing you're referencing is dentate. Yes, just in the interest of talking about a simpler case, I'm assuming that the person has a single arch denture. So if it's a double arch denture, you would just follow the reference denture workflow for both sides. And then when you had both dentures in the correct occlusion, you put them in the mouth and scan the bite. Again, so your laboratory will design using your bite block. So the bite block would be the ghostly purple outline here that your lab would use, and then they can see your scored midline and all that stuff and actually set the teeth right up against it, which is really helpful. Using the photo as well to get the teeth position where they need to be. And you can get your digital preview. Once you're happy with the design, then your laboratory will merge into a monoblock and print. Again, this is your third appointment, and I have the same picture because it'll be the same thing. Make sure that everything is good, because the final will be this plus any changes. I would really recommend the test drive thing. I think that's one of the coolest things about the digital process, is that you have something sturdy enough for the person to wear. Now, I get that it adds another appointment, but if you bring them in quickly and just say, hey, you tell them ahead of time, I'm going to be sending home a one color denture for you to try, so that way you can see what it's like in your actual life and let me know. Then you do all the photos and adjustments when the patient comes back. Probably not perfect for every patient, but if you have a patient who you think, they're going to be complaining about this thing, better to have them complain about this than the final. And then you can, even if you got to make another try-in, you can say, okay, well, I'm going to make all those changes and I'll let you try again. And then you can kind of get them. It's hard to get somebody to sign off on a wax up, because you tell them, yeah, I need you to sign off on this. Then the final one, the fit will be different. The tooth position will be different. The feel will be different. When they go to the final with this, the difference is this will be pink and this will be the same. So the person really can get a good feel for how it is. So again, procedure is the same as the previous process, and your fourth appointment will be the delivery. Again, I'm a huge fan of over communicating, so I'm going to beat that poor horse one more time. Talk to the patient about adapting to the new denture, what you've seen with your other patients, and make sure that they know about relines and replacements. It's a good conversation to have at the front end and also a good conversation to have at the back end. As you guys know, internally loaded bone stays and externally loaded bone tends to resorb. So if your patients choose to use implant therapy, they'll have more bone in a few years than they will if they're wearing a denture. And again, you can tell them if you do your relines properly, if you come in properly, I can make sure that your denture fits well, which will make your bone healthier. So always a good time to, give your patient options. One of the coolest things I feel like in dentistry that's changed since 1987 is that most everybody has a good option for what we can do for their teeth. Before implants came along, there were a lot of cases where we worked real hard and we came up with a real okay solution at best. Now we can pretty much help anybody. And I like that. That's really exciting. All right. So you said, oh, I love digital dentures. I want to do digital dentures. Problem is, I don't have an iOS scanner. So can I not do it? Absolutely not. So what we're going to talk about next is how you use your impression technique that we talked about last time to capture really good data and then transition into a digital workflow. Basically, what the goal of this is not only to get you a digital final, but to get you that printed prototype so that you get all the benefits of that as well. So if we're going to do a digital immediate denture, you'll go ahead and do your nice border molded impression of the patient's current situation, capture the video, everything else analog, and then send those to your laboratory and request a digital denture. Back in the lab, we'll go ahead and pour those models, articulate them, then we'll scan them on our laboratory scanner. And we can do either. Some laboratories will tend to extract on the physical model and scan that. One of the cool things about digital dentures is that if we're doing most of the ways that we make analog dentures, we have to destroy the master model because the denture is actually processed on the master model for the greatest degree of accuracy. With this, we're not processing on a model. We're just printing, milling. So we can actually try the prosthetic on the model, which is pretty cool. So most of the time, it's going to be nicer to go ahead and just, again, this is my single arch case, cut the teeth off here, smooth this out, scan it, and then build our denture. Your delivery and post-op care, of course, will be the same as it would be for an analog. I mean, for a more digital process. So what if you want to do an analog impression in digital dentures? There really isn't a good analog workflow for the reference denture workflow. You could conceivably take a reline impression inside your denture, take a bite. If your laboratory is nearby, send it to your laboratory, have them pour up the model, duplicate they just scan it. Scan the denture and then return it, but your patient's going to be without a denture for a while. So that's not awesome. So most of the time with this, you're going to be doing our 5 appointments, but what'll be different is you'll transition into a printed try-in or a milled try-in most everybody prints for this, and a digital denture at delivery. So just like we learned, you'll take your preliminary impression, your laboratory will make custom tray, you'll take your border molded custom tray impression, do your bite block. And so unfortunately, you're back to a 5 appointment workflow, but you do get the advantage of having the better fit and the printed try-in and all that stuff. So is it as awesome as a reference denture workflow? I would say not, but it certainly allows you to start. If you want to start doing digital dentures tomorrow, you can. What are some of the challenges with IOSs? One of my favorite things about intraoral scans is if they look good, they are good. In other words, if the software can't stitch an area, it just won't show up on your screen. One of the things that we find with physical impressions is that sometimes you get tray contact or poor polymerization or the patient moved or something like that. You look at the impression, it looks good, but it actually isn't. It's not dimensionally accurate. But there are some problems you can get with iOS records. Primarily what we run into is holes that are too big, discontinuities, and borders that aren't captured. So in all those cases, basically you need to add some more data to your scan. Printing or milling, we've been kind of talking about this quite a bit, so I'll go through it a little bit quicker. From a theoretic perspective, 3D printing is better than milling because when you're printing, you take a vat of liquid and you only polymerize the things that you need to create. So there's very little waste. And the wear and tear on the equipment is more predictable. Milling at the absolute point, like we talked about, at a micron level is slightly more accurate, but because of tissue deflection, it doesn't really matter. It doesn't create a perceptible difference for the patient. And one of the challenges is milling, especially in the maxilla, is that you, even with a 5-axis mill, you can get such a huge undercut that it's difficult to mill out accurately. So when digital dentures first came out, the first generation of printed materials were not awesome. And that really has been the limiting step. It hasn't really been the equipment. It's been the materials that we can load in the equipment. So a lot of those materials weren't that strong. They were kind of brittle and also prone to staining. For those of you who used them, you're like, this stinks. But the second generation, like we talked about, has really improved. So in phase 1, milling definitely had the edge because PMMA pucks, of course, very homogeneous, very strong, a great product. But as we've gotten into the second generation, now we're be able to print materials that are as strong or stronger than a PMMA puck in our printers. So I would say that as materials continue to evolve, probably milling will have the edge. It'll let you help your lab not go through equipment so quickly, and they can do a greater volume of cases for you, so you can get your cases back more predictably. And the anatomy doesn't matter in the sense that it doesn't matter how much undercut there is in the maxilla because the printer just builds it up one layer at a time. I feel like this is the next thing in digital, and I'm hoping that we see more and more of this. One of the things you might not have thought of that's very different from working in the laboratory to working in the clinic is that you see the patient's face all the time. You see their nose, see their chin, see their cheeks. There's a lot that you can see, their tongue, that isn't present on a model. Most of the time in the laboratory, especially with full arch cases like a denture or an all-on-X or whatever, we're using a proxy for the patient's face to understand how their face works. For instance, you carve up a bite block and we say to ourselves, okay, looking at the bite block in the photos, I can tell that this, if I put the teeth in this position, it'll support the person's face. I don't know exactly how it'll look in their face, but also, if I get a study model, it's like, okay, well, this is something that looked good in the person's face in the past. And this is different than a photo. So the way these are all turned facing towards me, but this is a 3D image just like the iOS scans. So when we do these cases, what we do is we actually align the iOS scans to the person's face. And then as we're designing on the iOS, the teeth populate within the STL of the person's face. So what's cool about that is you don't just look at it straight on. You can look at it in profile. You can look from below the chin to see how the lip position is. Takes a little bit to get used to it, but man, as a technician, once you get spoiled by this, it's hard to go backwards. It's like, I kind of like, and for you guys, it gives you the opportunity to do a virtual try-in. Now, probably most of you, the first time you do it, you'll be like, I don't know. But it doesn't take too long of the virtual try-in and the real try-in are exactly the same. You're like, I don't want to do any more real try-ins, or maybe real isn't the right word. I don't want to do analog printed try-ins. I just as soon send these to the patient, and you can get them hooked up with exocad web viewer and they can actually look at the design themselves if you want. So it kind of makes you the cool high-tech office. So with this, if you do a virtual try-in, you can really do a 2-appointment denture. So you do all the records we talked about plus a facial scan at the first appointment. Your laboratory do the design, send it to you, you'd review it, maybe review it with the patient, make any changes that are needed, and then go to process. And I've seen enough of these cases to where it's kind of funny. With this particular lady, as a matter of fact, this was an all-on-X case, and when it was delivered, she was sitting in the chair. So we took the design and we turned the design so that her head in the design was turned the same way as she was in the chair, and it looked exactly the same. It was like the coolest thing ever. So this is different than when a 2D photo is aligned to models or surface scans, because when you align a 2D photo, it's only accurate from one direction. As soon as you turn it, the relationship of the 3D iOS scan to the 2D photo isn't accurate anymore. So, so this is definitely a big step. Love this. If you get an opportunity to try it, I think you'll think it's cool. Copy dentures, may not be a huge market for this, but you can do a reference denture scan and then ask your laboratory to just make a copy of it. And so that way you'll get new teeth. You can have a different shade, new adaptation, but you don't have to go through try-ins and all that stuff. It's a cool, if a person's happy and they want a duplicate or something like that, this is a great way to do that predictably. So we're going to finish up by talking about digital overdentures. There are a couple different ways to do this. Earlier, we had a question about using the locator scan bodies, which is a good way. What I'm going to show you is a way that you can do this where your laboratory can convert it for you. So that way, when you get the prosthetic back, you can just snap it in. So it'll be kind of nice. This is be a 4-appointment process. So your first appointment is going to be a fixture level impression with scan bodies. So what you want to do is find the correct scan bodies for whatever implants you have and do a nice full arch scan. This, all you have to do is scan the master arch. You don't need to scan, you can scan the opposing if it's a single arch case at this time as well, but you won't be taking the bite. We'll be taking the bite with a bite block. So once you have your iOS taken, you'll go ahead and send this to your laboratory. And in the laboratory, we'll go ahead and print a model with digital analogs, and then we'll measure the tissue and get the appropriate locators, snap a metal housing and actually a black processor. I got a blue one showing here on the, and then we can make a bite block on this model for you. The bite block will pick up the little metal housings, so the bite block will snap in. So at your second appointment, you get the bite blocks. Here's my favorite bite block picture. And they'll be snap retained. Note that if it's a multi-locator case and you want shorter borders, be sure to let your laboratory know, so that way the bite block can also have the shorter borders. So the first thing you'll want to do is snap it in place and make sure it fully seats. If for some reason it doesn't, I would recommend cutting the attachments out and re-curing them chair side so that it's fully seated. Most of the time should be fine. So you'll, let me back up the truck for a minute. Remove the healing abutments, put the locators in the spots indicated by your laboratory, torque them to place, and then try in the base plate. The base plate should seat fully and snap. If it doesn't, remove the attachments, make sure it snaps, and then pick them up. Otherwise, you'll want to go ahead and do your normal bite block procedure. This, it's probably easiest to do this step analog and send the bite block back to your actual laboratory. So in other words, take a physical bite. You can do a 360 scan if you want. So at this point, you'll leave the locators in. So the patient will just be wearing them. Either if they have an existing denture, you might want to relieve it so it'll seat over there. Otherwise, you'll kind of use them as a healing abutment in the mouth to basically hold the tissue open. So then back in the laboratory, your technicians will take those analogs out of the model and put in locator analogs instead. And then at that point, articulate the case, do the design, and do a printed try-in for you. As in the other workflows we talked about, it'll fit just like the final, including it'll have snaps in it. So you'll be able to snap it in place and check the retention, check the fit, all that. Again, you have the ability of doing a test drive if you want. But your third appointment, so I did this picture. And then the fourth appointment, I'm showing a partial. There's a workflow in exocad that allows you to do a framework. So for most of your cases, you can do with the high strength materials that are available digitally, you can use just a normal printed prosthetic for your overdentures. But if you would like a framework, there's this exocad snap fit workflow that allows you to print teeth, some pink, a frame, more pink, and then assemble it all together. So this would be a 3D printed reinforcing grid work if you want. So same thing, the laboratory will still have your model. And again, the models don't have to be destroyed because you're not processing on them. And so they'll be able to cure your attachments in. And so when you get the case back, hopefully you just snap it into place. So you want to go through your same, your 8-step delivery process as usual and do any polishing. One of the things about this is you really want to talk to them about the attachment replacement schedule that they'll probably need to replace the inserts every 6 months-ish and the attachments, the abutments every 2 to 3 years. A good conversation to have at the front end. So your patient's thinking about total cost with this, not just the upfront cost. One thing to keep in mind, in general, the more parallel your implants are, the less wear and tear on the attachments. And you'll also make sure you coach your patients on inserting them by hand rather than biting them to place. That will help with the maintenance, with the attachments lasting a little bit longer. There's a question here. Can you have an open palate with a printed overdenture? Absolutely. And I would definitely recommend that. And with this overdenture workflow, I would talk with your laboratory either in person or through prescription back here. So when your laboratory makes this base plate, this is going to be snap retained. So you can go ahead and request, say, hey, this is a four locator case. I want a little bit of flange on the labial and I'd like the palate open. And they'll give you a great opportunity to try that out right at the beginning and see how stable it is. And then you can say, I like it a little bit longer, a little bit shorter. And then when you get to this point, you can try it out, try that fine tuning. Because our goal is hopefully this is perfect and we're just going to flip it to pink and white. But if it's not, we really don't want, our goal is for you not to be doing adjustments with your final restoration. Our goal is get this either perfect or pretty close, make predictable adjustments so that way you're not having to mess with it. And so I would say, with this process, you've got 2 opportunities to get the border right where you want it. And that's also an advantage to the try-in. If this border is shortened, then your patient can try it for a few days and say, oh, I really like that stability, or, oh, I feel like it's a little bulky, or, it's moving around a lot. Can we do anything about that? So kind of can make those decisions before you go to the final restoration. So good question. Thank you very much.